Good afternoon and hello everyone. Welcome to today's webinar on housing as a healthcare investment for children. Today on this webinar you will hear about the latest research findings on the connection between affordable housing and children's health from the Children's HealthWatch Network, a nonpartisan network of pediatricians, public health researchers, and children's health and policy experts. Research will help explore the connection between housing and its impact on the health of children, as well as lead into a discussion about how we can create effective collaborations between housing and health practitioners. And in order to have that conversation, we will actually learn about the Healthy Start in Housing program, which is an innovative collaboration between the Children's HealthWatch Network, the Boston Public Health Commission, and the Boston Housing Authority, which helps low-income families with young children requiring specialty health care to secure and maintain affordable housing. My name is Janet Viveros, and I'm a Senior Research Associate at the National Housing Conference. Joining me on the webinar today is Megan Sandell of the Children's HealthWatch Network and Gloria Meneses of the Boston Public Housing Authority. Megan is an Associate Professor of Pediatrics at the Boston University School of Medicine and Public Health and the Medical Director of the National Center for Medical Legal Partnership and a Principal Investigator with the Children's HealthWatch Network. She is a former Pediatric Medical Director of the Boston Healthcare for the Homeless program and is a nationally recognized expert on housing and children's health. Megan has served as a Principal Investigator for numerous NIH, HUD, and Foundation grants, working with the Boston Public Health Commission and Massachusetts Department of Public Health to improve the health of vulnerable children, particularly those with asthma. She has also served on many national boards, including the Enterprise Community Partners and National Advisory Committees at the American Academy of Pediatrics and CDC Advisory Committee for Childhood Lead Poisoning Prevention. Also joining us on the webinar is Gloria. Gloria is the Director of Occupancy at the Boston Housing Authority with over 29 years of service. As the Director, she operates in compliance with federal and state laws, as well as authority regulations and policies governing public and leased public housing occupancy operations, and has complete responsibility for the receipt and processing of public and leased housing applications, determination of eligibility both for priority status and admission, and maintenance of the public and leased housing wait lists. In addition, Gloria oversees the transfer process for all current BHA residents who wish to relocate within the public housing program. Gloria also assists with policy-making decisions and ensures that various policies and programs are effectively and efficiently implemented. Some of the programs include the Latino Health Institute, Elders Living at Home program, Justice Resource Institute, Housing Opportunities for Persons with AIDS, Program of All-Inclusive Care for the Elderly, and Healthy Start in Housing program, which we'll be discussing today. These supported housing programs were created with the City of Boston partners and have been successful in addressing housing and health disparities at the city, state, and federal levels. I'd also like to thank Capital One for sponsoring NHC's webinar series, of which today's webinar is a part, and also thanks to the John D. and Catherine T. MacArthur Foundation for funding the research in the brief that we'll be discussing today, a research that was completed by the Children's HealthWatch Network. However, any opinions or errors are ours alone. Now, before we kick things off, I do want to touch on a few more introductory notes. The first is let's address technical difficulties. While we hope the webinar runs smoothly for everyone, we know this doesn't always happen. If you run into any technical issues during the webinar, please use the Help menu or visit support.citrixonline.com for assistance. Also, I want to address a very frequent question, which is the webinar being recorded? Yes, have no fear. We are recording this webinar, and we will send out a link to an archived copy in the next few days, in addition to the webinar slides. Now, at this point, I would like to hand things over to Megan so she can get us started in our discussion today.
Great. Thank you so much, Janet, and we're really pleased to be here today. Again, my introduction was way too long, so I'm going to dive right into what we're going to discuss today. So the first is just a quick roadmap, a little bit of an overview of what is Children's Health Watch. We'll talk a little bit about what is known around these kind of three dimensions of housing quality, but two underexplored dimensions, housing stability and housing affordability. We'll talk about some of the previously published research from Children's Health Watch in a previous brief that we did with the National Housing Conference around homelessness and whether timing of homelessness matters. And then we'll talk about how child homelessness contributes to healthcare spending and how investments in affordable housing may be able to reduce infant hospitalizations. And then offer up just some overview of policy solutions before we hand it over to Gloria to describe the Healthy Start in Housing project. So for those that aren't familiar, Children's Health Watch is a nonpartisan network of pediatric and public health researchers. We're a research and policy center that has a mission to improve the health and development of young children by focusing on public policies designed to alleviate family economic hardships. Those hardships include things like hunger, also known as food, housing, or energy insecurity. And our goal is really to provide policymakers with the evidence to develop policies that actually protect young children's health and development. Our data comes from the front line of healthcare in Minneapolis. In those healthcare settings, we conduct a survey with the household, and we focus on interviewing families with at least one young child, a child 0 to 4 years old. And we focus specifically on this group because it's largely an invisible group. It's one that is not in school yet, and this is a really critical window for brain development. And so as a pediatrician, I am obligated to show you one super data geeky slide. So this one is around understanding human brain development. And what we know is that in the first 3 years of life is when you form generally the brain you need for the rest of your life. Particularly in that first year, you may be forming 700 synapses per second. And so when we think about why that brain becomes so important, we think about it from a child development point of view in terms of your long-term educational attainment and what that means towards your long-term ability to function in society, being able to earn a living. And so what we see here is that children that are not having a high school education have much higher rates of unemployment compared to, say, a child that's able to achieve a bachelor's degree, have much lower rates of unemployment, being able to contribute. And so when we think about what that looks like, we have a lot of research around whether or not you're ready to show up to kindergarten ready to learn. And you can see a lot of our briefs on our website around feeding our human capital and too hungry to learn. And so when we look at kind of the evidence for why housing matters when we think about early childhood development, obviously housing quality has decades of published literature around things like exposure to accidents or injuries based in the home from exposed wiring or needed repairs. Obviously a lot of evidence around the development and worsening of asthma and allergies tied to specific housing conditions such as pests, commonly cockroaches or mice, mold, chronic dampness, or tobacco smoke. There's been a lot of literature about lead exposure being tied to long-term effects, and then obviously nutritional issues related to anemia, developmental delay, aggression, and attention deficit disorder. But one of the things that isn't always tied very well to housing quality is actually behavioral problems. And so this is from the MacArthur Foundation How Housing Matters Network, Rebecca Levine-Coley at Boston College, which looked at how poor housing quality was actually the strongest predictor of emotional and behavior problems in the low-income children in that sample. And much of the associations between poor housing quality and children's well-being operated through parental stress and parenting behaviors that were affected because of that housing quality. One of the areas that I think is not as easily understood or explained is housing stability. And so we sometimes will talk about housing stability as kind of an iceberg where people will focus a lot on the part of the iceberg you can see, which is homelessness. And that obviously is the ultimate in housing instability. But we, in our research, typically feel there's a lot of hidden homeless, where people are housing insecure, defined as either overcrowded or multiple moves or behind on rent. and then really having difficulty affording housing regularly, even if they're not severely cost burdened, regularly having trouble making rent. And so in our Children's Health Watch research, we started to explore these ideas of housing insecurity and what that means to the health of young children. This is from a paper we published in the American Journal of Public Health in 2011. And there we saw that children in housing insecure families were much more likely to have kids that were in fair or poor health, to have kids that were at risk for developmental delays, particularly the ones that are severely housing insecure, moving 2 or more times in a year, and more likely to be seriously underweight. And these were compared to families that were housing secure. And then we also believe that affordability is really important. We published in a brief that just the simple question of whether you're behind on rent in the past 12 months is associated with really negative child and maternal health outcomes. Things like increased rates of lifetime hospitalizations, again, children being in fair or poor health or seriously underweight, and then maternal outcomes, mothers reporting they're in fair or poor health, or mothers having depressive symptoms. And so when we think about homelessness as this exposure, we were really interested in understanding timing. Does it matter? And the simple to answer that is yes, it does matter. We've published in previous research the comparison in birth outcomes, things like premature birth, less than 37 weeks, or low birth weight. And we compared women that were consistently housed versus those that were homeless prenatally, or people that became homeless postnatally, so had the same type of characteristics of people who became homeless. The only difference was the time they became housed. And so what we saw was that it actually wasn't the mother characteristics, it was actually the homelessness itself. That prenatal homelessness increased your risk for low birth weight, preterm delivery, and lower weight at birth, even after controlling for many different risk factors. We published recently in a brief in June of last year, Compounding Stress, looking at the timing and duration of homelessness on children's health. And what's important in this is that we actually controlled for these birth outcomes in order to look at this compounding effect. And here's some of the key bar graphs, which looked at the rates of if you were just homeless in the prenatal period, the red bar, if you were homeless just in the postnatal period, the yellow bar. But then you can see it's really the double effect. The dose response we're seeing here, where pre and postnatal have much higher rates of effects on child health, whether it be fair or poor health, risk of developmental delays, or child hospitalizations. And then it's interesting, we were also interested in the duration of homelessness. And we looked at, for instance, in young children, looked at whether they were homeless less than 6 months versus more than 6 months. And what we saw here was that infants, if they were exposed to being homeless more than 6 months out of their young life, they were actually 250% more likely to be in fair or poor health, or 100% more likely to be at developmental risk, and 46% more likely to have a child hospitalization. I just want to bring up the idea that housing spending can also be important in healthcare spending. And this book, America's Healthcare Paradox, written by Betsy Bradley and Lauren Taylor, is a really wonderful resource to understanding why do we have such exorbitant healthcare spending and how we may want to think about housing as a healthcare investment. So the paradox in America's Healthcare Paradox is this idea that we spend more on healthcare than any other industrialized nation. That's us all the way to the left-hand side, the United States. Many other countries spend 2 to 3 times less than we do. And yet what we know is that out of the 34 industrialized countries, we don't do very well for that spending. We're 25th in maternal mortality, 26th in life expectancy, 28th in low birth weight, and 31st in infant mortality. And so the authors tried to look at that paradox. And what they saw was that there was a difference in the ratio to social spending to healthcare spending. Kind of when you looked at the total healthcare spending, the ratio in the United States was very different. It's easier to kind of see it in this bar graph where the blue bar is the healthcare spending and the red bar is the lower social spending. And so when you think about it, for every dollar spent on healthcare, most industrialized countries that do very well with their health outcomes, they spend about $2 on social services, including housing. Whereas in the United States, for every dollar we spend on healthcare, we only spend about anywhere from 55 to 90 cents spent on those social services. And so when we start thinking about housing as a healthcare investment, we need to start thinking more creatively. And so we wanted to try and explore this idea of what were the healthcare costs related to homelessness. And so by our estimates in 2014, there were about 671,000 children aged 4 and under who were homeless at some point or were born to a mother who was homeless when she was pregnant. And by our estimates, 18,600 additional hospitalizations were attributable just to the experience of homelessness. When we start to break that down, that actually is $238 million nationally. And so we published last month this idea of housing as a healthcare investment. And what you can see here is that out of that $238 million, less than or over half of it is for kids under 12 months of age, $132 million just for infants related to hospitalizations, and then over $100 million for kids 1 to 4 years of age. And then additionally, we wanted to look at, in our data set, could we estimate what did compared to eating weren't receiving it. And so what we found was that those infants born to families that were food insecure but protected from having to spend a lot on rent because they were in a housing subsidized unit were 43% less likely to have been hospitalized than their other infant counterparts that were food insecure and not receiving that benefit. And by our estimates, that can be an additional $20 million or 1,200 avoided hospitalizations in 2015. And so this is just a graphic representation, again, in that housing as a healthcare investment, where we see that there's almost a 50% decrease in the likelihood in that first year of life after being born to a mom who was food insecure while she was pregnant, less likely that you're going to have a hospitalization. And so for us, it really is about thinking about these policy solutions. Are there ways in which we can expand funding for rental assistance programs and create more affordable housing suitable for families? We're really interested in making housing voucher programs easier for families to navigate and ensuring access to the supportive services for families who do receive rental assistance. And we think it's really important to consider vulnerable families as a special population, particularly as we hope to expand these rental assistance programs. With that, I'm really excited to turn it over to Gloria, who's going to describe just one such program in Boston called Healthy Starts in Housing.
Good afternoon, and thank you. Thank you for having us. It's very exciting that there is the interest in learning about what we're doing and what else we could do. The Boston Housing Authority is the largest landlord in New England. We have over 12,000 units on the public housing side that include Hope 6 and some finance and the public housing. We have over 25,000 people in our public housing portfolio. In addition to that, we have Section 8 programs, which include tenant-based choice, project-based, rehab, and some state vouchers. And we house over 11,000 families. When we look at the number of families that we're housing, then we have our breakdown of how many, sorry, not sure why it's moving faster. Okay. We have a waiting list of 39,097 families on our waiting list. And you can see on the breakdown of how many people are waiting, families are waiting for each bedroom size. When we have a portfolio of about 25,000 units, Section 8 and public housing units, and our waiting list is over 39,000 families who are waiting for a chance of affordable housing, even if we emptied out every single one of our units and vouchers, we don't have enough units to assist all the families who are waiting just for the Boston Housing Authority to give them an opportunity of affordable housing. In the elderly disabled housing program, where we also see an increase of need of housing for the elderly, we have 8,395 elderly, 62 and older, and disabled individuals, as you can see on the screen. When then we look at the breakdown of the families that we're assisting, over 91% of our families have have less than 30% of the area median income of the city of Boston. The median income is $95,000 for the city of Boston, which means that $28,000 would be the median income. However, our families make less than $14,000 a year. We are housing 44% of families with children, 26% are families with disabilities, head or co-head. This does not include the number of children and other household members who have disabilities. So the number of families that we're housing with disabilities is greater than 25%. We may have families that have a family of 5 and all 5 members have some type of disability. Boston Housing is a place to call home. It's our communities. It's a place where people are going to be living safe. When the BHA has made a decision of who we're going to house, given the need of affordable housing, we have elected to prioritize the people in most need. So the 39,000 families who are waiting, we have families that we house, is 75 to 80% of the families that we have housed are either homeless, in shelter, hotel, motel, who have been put or evicted, have been victims of domestic violence, inaccessibility to their dwelling unit because of disabilities. We house the families that are their income under $14,000, and as I said before, many are with multiple family members with disabilities, cancer, depression, mobility, visual, and other impairments. In addition, we have families that have language barriers. They come here to the community for the first time, or they've been here, but they really haven't been able to get to have proficient English. So that's a barrier for them. Household members that have no immigration status. We have state portfolios that does not require at this time any immigration qualification. That may change in the future. Or it includes families who have mixed households where some of the family members have immigration status and some don't, but they wouldn't be able to afford a federal program because it would be too expensive. Households that have come from Africa, Nigeria, Kenya, South America, Central America, many other locations where they have lived war and they have fought to have a better chance in life. So they come with some post-traumatic stress disorders, households of only one parent, lack of support systems. They don't have anyone. It's just them, no one else to help them. In addition, they have criminal records that when they go out in the private market, somebody runs the criminal record and they are immediately rejected from a place to live, even if they're going to pay all their income towards rent. Dealing with substance abuse, need assistance and guidance on how to, for the first time, I'm going to have my own apartment, but I really haven't have a place to live. So how do I clean my apartment? How do I maintain my maintenance? How do I do my budget? Difficulty understanding the many policies, either because of language or comprehensive, not the education level that is required. And right now we're facing nationwide a lack of affordable housing and an increase of funding cuts, forcing the housing authorities to look at ways of how to be creative and therefore actually losing more affordable housing to be able to keep up with the current existing units that need to be repaired, renovated. So we're looking at less units available for the growing families in need of affordable housing. So Boston Housing Authority is a community where we house people. Someone looks at someone as being homeless, may not see really a family as a family. They just see a homeless and a problem. The BHA, therefore, has, knowing who we're housing, looking at the statistics and the needs, that housing someone is just not the only solution. Housing is just the first immediate need, the basic need of having a place to live. But then we have families, as you saw, that come with complex challenges. We have created a number of supported housing with many agencies here in the city of Boston to try to assist our families. And these agencies are bringing services to our families and our communities and provide individualized services that are tailored to assist our vulnerable population to help them then become self-sufficient. Healthy Starting Housing, Home Base, PAYS, ELAP, Summer House are some of the supported housing programs. Healthy Starting Housing, it's a program that has been created since 2009, which we look at the infant immortality, and BHA engaged in providing 75 units to women who had high-risk pregnancies. And if they had not found housing, the likelihood of their child being born and to become healthier, it was less likely. We have been successful of stabilizing families, the mom, the baby, siblings, a household into their own units, and have seen them becoming stable of housing and stable with their health. And not just stable, but being successful to then be able to look at a vision beyond just taking care of my health and taking care of housing. Many of our families have now graduated from the Healthy Starting Housing, have their own tenancies now. They either have now moved on to purchase their own homes. They have gone back to college, graduated. They have now acquired nursing, because they said one got inspired by the nurses who were coming to assist them to be able to give back to the community. So this has proven that housing alone, it's not just the solution. We need housing, and then if we have partners that help us, Boston Housing Authority is the landlord. We don't provide the services. But hooking up with the agencies who do provide those services and working together, we're able to make a difference in so many families and make a healthier America. These are the families that we house. This is the future of our nation, not just the city of Boston, Massachusetts, but it is our future, our children, our generations that we need to invest in. Where the money is going to come? If we're able to cut on the cost of health care, perhaps we could increase the dollars on really providing affordable housing in public housing, Section 8 voucher in some form, but really give people the opportunity that they deserve. And working together, I know that we could do a better job. And now we'll pass it back to Megan.
All right, so we are really excited to start to hear more about your questions and focus on some of these policy solutions. And so with that, we'll turn it back over to our moderator, Janet, to see if we can see if there are questions that people have.
Great. Thank you, Megan. Thank you, Gloria. So while you're all thinking about your questions, I want you to know you can submit them via your GoToWebinar toolbar on the side. And as you submit them, I will pose them to Megan and Gloria. But before we do that, I also wanted to mention that you could read the full reports that Megan mentioned on the study on the impact of homelessness on children's health, as well as access to rental assistance. And they're located at www.nhc.org on our website. We had the great opportunity to work with Megan and her team to think not only about the results, but about the policy implications. And so in that vein, I do want to pose a question both to Megan and Gloria about the Healthy Start in Housing program in particular. We have a lot of housing providers and developers and other advocacy organizations that see in their daily work what Megan and her team were able to show in those graphs and charts, that affordable housing is really a critical base for supporting health in children. But the next step is usually really challenging, which is how you actually put those data points into action. So I'd love to hear more about how you are actually able to start this Healthy Start in Housing program. How do you actually go about pursuing a collaboration between two different agencies that often function in isolation and silo? And do you have any lessons learned that others could apply in their work?
Yeah. So I'll sort of kick it off and then I'll throw it over to Gloria. Is that, so one of the things that we learned from our initial Children's Health Watch research was that really there's no safe level of homelessness, right? Like homelessness is a bad and toxic exposure whenever it occurs, whether it occurs prenatally or postnatally or both periods. And so it's really about preventing homelessness. And that becomes really important because one of the things that we've talked about is, are there ways in which you can identify families that are on the road to homelessness or in the pipeline to homelessness? As you remember that graphic image of the iceberg, they're kind of below the surface, but they haven't kind of sprouted up. And so one of the important things about Healthy Start in Housing is it screens for women that are high risk, right, at risk of having a bad pregnancy outcome, like low birth weight or prematurity. And again, this is ultimately a way to really reduce infant mortality and help kids have a healthier start to their life. But it's also about identifying women that are housing insecure. They're not homeless yet. They are doubled up with family members. They're moving frequently. They're, at risk of homelessness, and identifying them in that critical window and then fast-tracking them into Boston Housing Authority housing. And so the thought here is that it's a special privilege to be able to be fast-tracked, as Gloria really mentioned, right? The waiting list doubles the amount of space that they really realistically have for people, and right now being homeless is the top priority. So it's really trying to test by having a different priority system, can you use housing as healthcare? I will just put in a small plug before Gloria takes over. We're actually excited about the prospect. We just completed a planning grant to think about a similar project for young kids that we're going to be starting hopefully soon. And so that I think, again, we really want to try and innovate more and more in this space of thinking about identifying people before they're homeless and being able to intervene with this housing and social service network.
At the Boston Housing Authority, there are housing authorities out there looking at how do we do this, how do we replicate, because that's what we would like to see being replicated. We have in our admissions continued occupancy policy in the ACUP, a provision allows us to create supported housing programs. So that's the first thing, is look at the policy and see, do you need to make a change? Do you need to go through a public hearing and make that change so that your agency is allowed to create supported housing programs like this? We have it in our ACUP, and then looking at the population that we serve, learning from the many agencies that are here that provide services, because what we see is a replication of work because there's no communication. There was no communication among the many agencies servicing the same family, but no communication. So actually we spent more money, more frustration for the family and for us because we couldn't talk. Well, we didn't know that we were servicing the same family. By creating the supportive housing program and an MOA, a memorandum of agreement with the different agencies that are going to be servicing the families, educating the service providers about our housing programs, and we become familiar with what the services are out there that may be provided to the families. Then we provide the housing. We're not the experts of the housing authority regarding health care and other service needs. The healthcare providers, they are the experts. So each individual household then is met with, an assessment is made, and what exactly is it that the family requires? First is it's the health risk of losing a baby, then becoming housed. But then after that, how do you provide the rest of the services? So we created a memorandum of agreement of what are the services that the housing authority will provide housing, and the healthcare providers and other agencies that will be involved, what are they providing? We create that memorandum, and we're able to talk among ourselves and with the client, and together be able to provide those services and decrease the already high frustration that the families come with, making it a better and stronger relationship and a more pleasant experience for the family.
Thanks, Gloria. We actually had another question come in about the Healthy Start and Housing program, and I think you started to talk a little bit about this in your presentation, but the question is around whether this housing that you make available from the Housing Authority for these at-risk families, is it temporary, is it permanent? Do you have a sense of how long the average stay is, or a sense of what role the housing and those services offered in partnership with your partner agencies, how effective is that in helping people achieve self-sufficiency as well?
It's permanent housing. It's not temporary. I mean, a lot of the families are already in temporary housing or unstable housing. So we have allocated a specific number of units, our supported housing units, 75 in this case, and they're permanent. And we did allow in this program for graduating, so when the families become stabilized not just in housing, but financially and health-wise, the family could decide they remain for good in their units, or they may move on, which we've seen many of the families gone into the private market now that they have higher incomes or they have purchased their own home, and some remain with us, no longer requiring those services because now they have become self-sufficient. So our program is permanent housing.
Great. Thank you. There's also been a couple questions that have come in looking for a little bit more detail on the services side and the funding. So I assume from what you're saying, the housing itself is funded by the Housing Authority and the services are funded by the service agencies. These are services they were already offering but not necessarily in coordination before. Could you confirm that and also speak in a little more detail about what kinds of services are available and offered through this program?
That is correct. We provide the housing and the funding we already are receiving either from the state or the federal government. So the family will be housed there. They pay 30% or 32% of their income based on which housing program they're housed. And the services that they're provided is individualized assessment. Many families may require a nurse that are coming to check in because it's difficult for the family to actually go to the healthcare provider. The healthcare provider comes, checks on the child, checks on the parent. It also may be mental health that is provided. We've had a lot of our families, women who faced rape, overcoming the deep depression. It could also be on financial, parenthood. It's first time being a parent, or it's the first time ever being on your own and not really have an example of what is really healthy parenting. So it depends on each individual family, what they have gone through, what traumas they might have gone through, financial needs that they may have had, connecting them with the appropriate, even WIC. Some families don't know that WIC exists. What services out there that may help them? So each service provider will make that assessment for each family.
The services predominantly are part of the Boston Public Health Commission's Healthy Baby Initiative, which is typically state and federal funding where, again, you identify high-risk women who are at high risk to have, say, higher rates of infant mortality, and so they're able to tailor it. And then some of the other more innovative therapies that have been used have been things like problem-solving education, which was developed here at Boston Medical Center, this idea that it's very common for women to face a lot of issues that result in depression because they're so overwhelmed having to work so hard and take care of kids and have a lot of these really difficult trade-offs. And so part of problem-solving education is helping people cope with those types of problems that often arise, and that is so that it's not only kind of treating existing depression, but it's also trying to prevent depression in the future.
Thank you. Actually, more on that topic, there was a question that came in about whether either of you could speak to some of the mental health and behavioral impacts specifically for teens and young adults. I know that the program we're talking about and the research we're talking about is specifically looking at young children, but I was wondering if either of you had come across either some research or just some experience in your work on the impact of having affordable and stable housing and also access to these services, what impact that has on teens and young adults.
Yeah, I think it's a really good point. I think that often, and I am a pediatrician, so I will totally be guilty of this, that we focus mostly on the kids, but we don't often focus enough on their parents. In our Children's Health Watch research, we oftentimes will report on both kid outcomes and maternal outcomes. About 92% of the people that we interviewed during the household survey are mothers. And oftentimes we'll actually see higher rates of bad maternal health and bad mental health in the the adults than we will over the kids. And so I do think that it's really an important idea around how does housing impact mental health, and there's more and more evidence that it impacts it through, housing quality, housing affordability, housing stability, and other things. There is other published research out there with housing as a mental health care investment, and it actually shows that it typically can pay off also because oftentimes mental health is extremely expensive to the healthcare system. I think that in this case, we're focusing on young parents with young children, and so I think that we could probably repeat the analysis. We were focused just on healthcare utilization among these young kids. We could probably repeat the analysis and look at the maternal health outcomes and see whether or not we could project to maternal health benefits as well.
This is Gloria again. With the Healthy Starting Housing supported housing program, there is a video that the Boston Public Health Commission has available on the website for the Healthy Starting Housing program, with some testimonies of the families, women who have been housed with the BHA through the supported housing program. And it's very emotional to see someone, this one particular individual, when she's giving her testimony and breaking down of she had lost hope completely, no hope, and couldn't believe that she was given this opportunity. And she said she was so deep in her depression, she couldn't see beyond anything else. And this pretty much saved her life, her mental state, her life, then to know that she could become a good parent. She could become a parent that she couldn't become before. She couldn't be before. Some, because of depression and not seeing an option of a better life, self-medication, which self-medication, pain medication become then drug addictions. So families then part of trying to incorporate are substance abuse. That's not realizing that trying to forget and be able to cope, you're self-medicating, and then there's addictions. So I'm pretty sure that looking at the statistics and getting all the data, what we gain by providing both the affordable housing in addition to the services that each individual family requires, it's a major saving and a positive impact for our society.
That actually provides a great segue, Gloria, for another question that came in, which is about using social impact bonds or pay for success as a financing solution for providing more affordable housing. And I think the question is trying to get at whether this is something that the Housing Authority has looked at. As you mentioned before, Gloria, not only is funding for affordable housing not growing, it's essentially shrinking and making it, I imagine, infinitely harder for you to do what you do at the Housing Authority. Is social impact bonds a route that the authority has looked at or would consider? And Megan, are there any programs that your organization has looked at that might have some information on the effectiveness of that financing model?
Yeah, that's a really good question. I do think that social impact bond financing is still relatively new in the United States, only about 10 or 15 demonstration projects. A lot of them actually have focused on kids. So one of them is actually in Cuyahoga County outside of Cleveland, and looking at actually homeless families with children where the kids are in protective custody. They've been removed from their biologic parents, are in the foster care system, and they actually are reunifying those families with housing and supportive services. And if they reunite at least 25% of the families, the social impact bond will pay off. There's another one in Denver that again is focusing on homeless individuals, being able to do this kind of supportive housing model. I think that they're definitely, for a certain subset of the population, and I'll be honest, I'm not aware of one in the pregnancy space, the healthy starting housing, but I'll be honest with you, one severely premature baby can cost the healthcare system $250,000 to $300,000. So you could imagine it paying off pretty well if you set up the right social impact bond. But I do think that you have to target the right population and for it to work, a very high cost population. But it is, I think, a really good example where by aligning services better, you actually not only can have better outcomes, right, but you can also save money.
And by saving that money, we're hoping that Congress will look at this and really reconsider of reallocating the funding to affordable housing. Yeah. Affordable housing, whether it's in a voucher program. And I've been 29 years working in this business, strongly believe that even if you give someone a voucher to go to a higher income suburban area, it doesn't assist the individual, the families, when they don't have the services in place. So it's kind of creating a failure for the families. I know that there's a lot of push of deconcentrating poverty from areas, but if you're going to bring families outside from where their support systems are, you really need to create those services. So we're hoping that by creating more and more of this type of supportive services, supportive housing programs, whether in the Section 8 program, voucher, and the public housing or any other mixed finances, that the services are really there. I mean, we see families who are being, who are homeless, who have become homeless because they could no longer keep their units, and either foreclosures or non-payment of rent, who are end up being out of the city of Boston and being and the kids being transported to Boston, costing the house, costing the city, costing the state less of money, funding of bringing the children back to Boston for school or for the health care that they require. So I believe that infrastructure changes and reallocation of the funding appropriately. It's much needed and looked at, and this is just one little program that we have created that we know could be successfully replicated throughout the state and the country.
Thank you, Gloria. Kind of building off of that vein, so your point, Gloria, is that it's obviously housing is the critical base, but it's the services piece too that's really essential in helping families succeed. And so there's a question that came in on what exactly is funding that coordination. So the Boston Housing Authority's role is to provide housing, the Boston Health Commission's role is to provide health services, but the actual effort of collaborating and coordinating and working together takes time and effort. And so who is funding that time and effort?
Nobody. Actually, we would like to have the funding because we just continue doing more, like they have trained us, do more with less. So we would love to see the funding to be able to pay for that coordination. But we feel the fundamental of showing that we are doing the right things, and hopefully that others are going to see and notice, and as the reduction in the health cost is done, and also when we are stabilizing the families in affordable housing, that funding is reallocated and the housing authorities and the service providers are actually funded appropriately. So we could really have affordable, decent, safe housing for the families and the services that are required. Because every time that Congress come by, who gets cut? Services and housing.
Yeah, and I think that it just speaks a little bit to this idea of, particularly when you look at the healthcare dollar like dwarfs the housing dollar, right? You know, like HUD's entire budget is between $40 and $50 billion, and the Medicaid alone is $500 billion across the country. Medicare is about $1 trillion. So when we start thinking about ways in which housing can be a healthcare investment, I just want to kind of underscore Gloria's point that if you're investing in housing and you're seeing savings on the healthcare side, you need to reinvest those dollars on the housing side, right? We need to be able to figure this out. And I think that in a lot of ways, one of the important things to think about is this idea of aligning existing resources for efficiency. And I think the question is right. That doesn't happen overnight. You need to really build bridges and be able to think about it. but that in doing those kind of efficiencies, you may actually be able to have some savings. But I think the key here is that those savings then need to be leveraged so that they're investments for more people to be served and things like that. I think that in this important, we on the healthcare side often have a lot of resources around, say, services, but we place them in the wrong places. We put them in like a case manager in the middle of our pediatric clinic when it actually may make more sense to invest in a case manager that can visit housing or a case manager that lives in a social service agency. And so I think that within the healthcare world there is this kind of, do you build more social services within our four walls? That's one way to kind of bend the ratio between social and health care expenditures, but I actually think it's better to bend it the other way, which is shipping more healthcare dollars out the door to investing in housing and social services outside the four walls and buying it externally instead of building it internally, because you may be able then to get a better ratio and actually a better return on your investment.
Thanks, Megan. I think that's probably something a lot of housers would strongly agree with you. We also had a question kind of coming in along those lines about the Affordable Care Act changes and specifically the community benefit provisions for nonprofit hospitals that require them to spend on a variety of things to justify their tax exemption. One of those eligible areas is community building, and so the question is whether this program or just in general, the Housing Authority, the Boston Health Commission are partnering with hospitals and leveraging their resources through the community benefit provision, or whether that's an area of potential opportunity to shift this alignment.
Yeah, I think it's a really great question. So in some ways, we had been talking previously more about the payer dollars, right? The dollars that a health system may have either through insurance or provider agreements, and thinking about healthcare, housing as healthcare investment on that side. I also think there's another kind of dollar within the health system, which is the community benefit dollar. For those that may not know, most health systems are not-for-profits, and by that it means that they don't pay taxes on their profits, and many of them make good profits, and so they're supposed to do and file with the IRS regularly these 990 forms, and on those 990 forms they say these are the community improvement activities that we're doing as a way to offset what we should have paid in taxes. And so one of the interesting things of note is the American Hospital Association and the Catholic Hospital Association last year actually petitioned the IRS to have safe and clean housing, and I'm using air quotes for those of you that are not seeing me, is this idea that clean and safe housing could count as community improvement activity. Housing had been on a different part of the form before, but the improvement activities is on the front end of the form. And the IRS ruled in December, yes, that actually it is now considered a community improvement activity. And so there is now more and more engagement around doing these community health improvement processes where you do a community health needs assessment, you look at the needs of the community, and most times if you're looking for needs, housing should rise pretty high, whether it be affordable housing, quality housing, housing stability, and then trying to engage in hospitals and health centers to do community improvement activities. There's some really nice examples across the country. Nationwide Children's Hospital in Columbus, Ohio has put up to $5 million into its South Side neighborhood in Columbus as part of its community benefit. But I do think that here in Boston it's been a little bit of a harder alignment trying to get the different hospitals hopefully to doing one community health needs assessment and then starting to get them engaged with spending some of their community benefit dollars on housing itself.
Looking on the housing side and the number of reasonable accommodations that we see on a daily and weekly basis, some of the community changes and housing changes, which require money, appropriate funding, it's mobility impairments. There's an increase of mobility impairments because people are having problems with knees and feet, and many of the construction, at least here in the city of Boston and surroundings, are high-rises. and we keep looking at our portfolio and try to continue making policy changes and wherever possible to make accommodations, but there's an increase of need of units that are first floors and 0 stairs because people cannot negotiate. And as we have families who with disabilities where the housing that was available for the mental people with mental disabilities have been shut down, they have been closed, so the only real affordable housing is the housing authority. Which means there's also different types of services that are required. I mean, and people that have families, they are dealing with their own challenges, mental disabilities and mobility challenges, or their children. So we need to be able to have the appropriate funding to create the appropriate housing for the needs. Mobility, it's a big one, which may seem simple, but when you look around a lot of the constructions where they're high-rises, it does not really accommodate many of the disabled, which means where are they going to be housed?
Thank you, Gloria. With that, we're going to have to close out the webinar, but I'd like to thank both Megan and Gloria for sharing their work with us and answering everyone's questions. We still have many more questions that we didn't have time to get to, but I will follow up with Megan and Gloria to see if I can provide some contact information to everyone who wants to follow up and learn more about the Children's HealthWatch Network, as well as more about some of the innovative programs out of the Boston Housing Authority. So thank you again, Megan and Gloria. Thank you everyone for joining us today. I'd also like to thank Capital One for its financial support for NHC's webinar series. It helps make it possible for us to share this exciting work with everyone here. And also thank you to the MacArthur Foundation for funding the research conducted by the Children's HealthWatch Network that's contained in the brief that Megan discussed today, Housing as a Healthcare Investment. If you want to read that and the other brief Megan mentioned, as I stated before, it's on NHC's website. But if you have any further questions or thoughts that you'd like to share to continue the discussion, you can also email me. I'll include my contact information as well as a recording of the webinar slides, and some of the resources that were referenced in the discussion in an email that will be going out to everyone who signed up and attended, and that way we can keep the conversation going. So thank you all for joining.
Thank you.